honored to introduce Dr. Nina Irawati as our invited speaker. Dr. Nina Irawati completed her surgical training in the University of Indonesia, Jakarta, and became a general surgeon in Ambrose Hospital, Batam, Indonesia since 2008. She finished clinical fellowship in head and neck surgery in Takta Memorial Hospital, Mumbai, India in 2013, and head and neck surgery and plastic reconstruction fellowship in Sheng-Po Memorial Hospital in 2015. Dr. Nina Irawati is currently a senior consultant at Dr. Sutomo General Hospital, Indonesia, as well as decorative student at University of Indonesia. Today, Dr. Nina Irawati's presenting topic is flap in head and neck. Please give a round of applause to welcome Dr. Nina Irawati.
Good morning, Peter. Can you hear me?
Yes.
Hi, everyone. Thank you for such a generous introduction, and thank you for Professor Hall. It's been a privilege to be invited. I was, as Peter said, that I was Professor Hall's student, and I learned a lot from him when I was there back then in 2015. It was a wonderful experience. So without overdue, I'm just gonna share my screen. Is it already in PowerPoint?
Yes.
Okay. So this morning, we're not going to talk about some serious things. We're just going to talk briefly about what is the flaps that we commonly use in forehead and neck reconstruction. I have nothing to disclose for this presentation. That is my institute. So when we think about how to reconstruct the defect in forehead and neck or for any defect in the body, then surgeon usually refers to the reconstructive ladder. And this ladder does not only consist flap, but also other common techniques such as skin graft and even primary or secondary closure. It also consists from the least or less complex technique up to the very complex technique. And how do we choose what kind of technique that we need to reconstruct this defect? First of all, the first one will be, we need to analyze the wound first. What is the types of the tissues that missing? How much of it? And the reason is because the aim is to replace like with like. So bone with the bone, soft tissue with the soft tissue. And we're also trying to provide sufficient volume. We're trying to replace the volume of the defects that missing from the ablative surgery. And then we also need to know what is the anatomic boundaries. For example, if we have the defect in the nose and the cheek, so our reconstruction should also define where is the boundaries between the nose and the cheeks. You don't want to have a reconstructive surgeon who reconstruct your defect and then just put a flap, which is completely flat. There is no boundaries between the cheek and the nose, for example. And then we also need to know what is the function that lost or diminished from the ablative surgery, and we're trying to restore that back. We also need to evaluate what is the patient's goal and prognosis. Sometimes we have such a very high expectation. This flap, the free flap, probably the best and ideal situations for many cases for complex head and neck. But if the patient is not suitable for long surgery, or you do not have any staff or any supporting systems that can actually give you benefit of doing free flap, then you need to think about and rethink about other plan, which is more simple, easy to harvest and everything. And of course, the external factor, which I just mentioned before, about your staff, including the experience of the surgeon, the staff, the equipment, the supporting system, and whether you have ICU or a high care unit, for example, for the post-recovery patients for such a complex reconstruction. So here, we need to select what is the right procedure for the right patients at the right time and in the right place. So what is a flap? Flap is a tongue of tissues, consists of entire thickness. It can be consist of skin with a subcutaneous tissue, and it can be transferred from one side to one another. And according to blood supply, we can have random flap. Random flap is when you don't even see where is the pedicle of the vessels of the flap. You just randomly move it around to close your defect. For example, nasolabial flap can be random, can be axial. Axial flap, when the blood supply is based upon a small named artery. So sometimes when you raise nasolabial, you don't often see the pedicle itself. You can just moving around. But of course, you have to know the thickness that you need to raise so the edge of the flap won't be necrosis or something like that. And then there is also pedicle flap, where it is supplied by a large name artery, for example, pectoralis myocutaneous flap. That is one of the pedicle flap. And as we know that we have free tissue transfer or free flap, which is harvested from remote region, and the vasculars are established at the recipient site doing with microsurgery technique. Machesnahai in 1979 has 5 types of classifications of the flap based on this vascular. So sometimes it can be one dominant, and then there is another non-dominant pedicles that can also supply the flap, or probably the flap only have one vascular dominant flap. According to the flap content, we have cutaneous when it consists of skin only, fasciocutaneous if it contains of fascia and skin, and then of course if contain musculocutaneous, then it takes the whole muscle, the skin, as well as the fascia. From the method of the transfers, then we know that there is an advancement flap when you mobilize the flap just along a linear axis towards the defects, and then transpositional when you have to rotate it or even transport it over an incomplete bridge of the skin, and then rotational if you have a pivot at the base of the flap. Interpositional, for example, is Z-plasty when you mobilize it to a defect over an incomplete bridge, which the bridge also need to be elevated and mobilize it. Interpolated flap, you need to mobilize it over or under a complete bridge of skin, for example, in forehead flap. According to the configurations or the shape of the flap, then we know that there is a below. This is the left pictures, upper left pictures is when we need to reconstruct it, the defect, which is like rounded defect. So we can't have a below flap to close the defect. And then rhombic or limber flap, where you have a defect either at the cheek or a temple of the face, and then you can move around, and then it's gonna be like a limber, just like in pictures down below on the left side. And of course, Z-plasty. According to the location, we have local flap if it's so close to the defect, regional flap if it's near but not that close or in immediate proximity, and then distant flap when you take it from somewhere else and then you just harvest it, and then by microsurgery, you reanastomosis the vessels itself. So what is the goal for local or regional flap? You need to match the color. You need to have adequate thickness. If possible, you also preserve the sensory innervations. It has to be very lax. It cannot be very tensioned. And then if possible, you trying to hide the scar within the natural skin lines. So let's talk about local flap. In local flap, we have also advancement flap. We know that the advancement flap, it has a criteria where you can mobilize it through the linear configurations. You can use it for everything, for forehead, for nose, especially tips or ala, and then lips, cheek, and intraoral as well. The disadvantage will be decreased vestibular sulcus of the depth, and it's indicated when the surrounding tissue has a good skin laxity and scar can be hidden in skin crease. For example, if you have a lesion in a buccal, You can use a buccal advancement flap, for example, to close the lesion either in the buccal itself by sliding it, or you can transport it to other places around the buccal or the palate itself through the tunnel. And then local flap also has rotational flap, where we already know that by rotations means you can mobilize it with a pivot at the base of the flap. It can be random, it can be axial, it can be used for the nose, for the palate, for the scalp, for anywhere which has a very laxity. For example, that we know that if you have the defect at the tip of the nose, then there is an axial frontonasal flap where you mobilize the skin over the nose above the defect, and then you rotate it on its vascular pedicle. Axial frontonasal flap has a blood supply from supraorbital, so usually it's in the inner canthus of the eye. So you rotate it on that pedicle to reach your defect at the tip of the nose. And then palatal flap, usually we can use it for either if you have like a fistula in the palate, you can rotate it. It's a very good flap supplied by a great palatine artery, and it's a very easy and very robust flap as well. Buccinator myomucosal island flap, or even what we call fan flap, because it's based on the facial artery blood supply. It can be used for anywhere, including the buccal defect, the palate. So you can rotate, you know where the artery, the facial artery locations at the cheek, and then you use your cautery, make the depth like quite deep incisions, which is included the mucosa, and then as well as some part of buccinator, and then you transport it or mobilize it to close the defect in the buccal, palate, tongue, or sometimes you can put it for marginal mandibulectomy defect as well. It's based on superior, based on facial artery flap, or inferior facial artery flap. So you can rotate it wherever you need the flap to reconstruct your defect. And then local transposition flap, you can also use it for the tip, for the ala, for the inferior eyelids and lips itself. Basically, one border of the flap is also the border of the defect. So, for example, this is limber flap. It's a melanoma from the left cheek that we reconstruct using this flap. So you can see that when you rotate it, it's actually mobilized it on adjacent incomplete bridge, which is a little bit triangular, but not complete. And then from this local flap, you can see that sometimes you cannot hide the scar that good, but by using these transpositions, then at least you can hide the scar between the nasolabial skin crease, for example. But of course, you cannot hide it in any other part of the flap itself. And then below flap, you can always rotate it whenever you have like a very rounded, very small lesions that has surrounding lax tissue as well. Interpolations flap, the good thing about it, it's a good flap with a good texture and match. The disadvantage that can be your consideration and for patients to consider to have this flap is because it requires second surgical procedure. And we commonly use this interpolation flap all the time, especially for head flap. This is paramedian, where we need to reconstruct for the defects around the nose, dorsum of the nose, and then we also need to have like a little cheek part of the nose as well. We reconstruct it with a paramedian for head flap, and then we cut it 2-3 weeks after we raise the flap. And then this is a case lateral forehead flap. In this case, the ideal flap will be either ILT or radial forearm flap. By that time, the patients refuse to have free flap, and then her general condition is also not suitable for a long surgery. Hence, she chose to have lateral forehead flap. And then we have nasolabial flap, where you can use it and transport it for the cheek or for the lips or for the nose reconstruction. And then this is ape flap. Ape flap, usually we use it for reconstructing the upper lip. And then you place the flap, you rotate it, and then you cut it. After 2-3 weeks, you harvest it. Tongue flap, you can use it for the defect in the palate or on the cheek, or even if you have a marginal manipulectomy defect, for example, that the patient is not suitable for any radial forearm free flap, then you always can use it. The problem with the tongue flap is if you raise it too thin, then most of the time the tongue flap will get necrosis. So you need to measure that the thickness should be around 1 centimeter, with the width also around 1 centimeter at least. Um, there you can get a very adequate thickness of the tissue, so your flap usually can be viable after some time. So what is regional flap? Usually you use it for medium to large defect to restore the missing tissues. And it can be from anywhere. Most of the time for head and neck reconstruction, we use it from the chest, from the neck, or even from the axilla, from the back. The advantage is this is a very robust flap. I like it so much because most of the time we need a quite complex reconstruction for complex head and neck. The advantage is it's very bulky. Sometimes the texture is not matching, the color is not matching, not like local flap where most of the time the texture and color just melt. And sometimes most of the regional flap is very bulky, although it will shrink off most of the time, but sometimes for the patients, they're a little bit hesitant to have this kind of flap because it's just too bulky, especially for female patients. This is my favorite flap, PMMC flap. You can use it with only the muscle or you can use it with the skin. I usually like to use it with the skin because sometimes you need the vessels around the skins, which has a lot of perforators for the viability of the flap. It's supplied by thoracoacromial artery. It's very robust, easy to harvest. It's very quick. I used to be trained at Tata Memorial, and we used to be trained to raise it in 1 hour and then put it back for inserting for another 1 hour. So this is for those people who doesn't have any experience in free flap, have a very complex head and neck ablative defects. PMNC can be one of the options because it's very robust. The pedicle is very strong. You cannot easily injure it. It's very hidden behind the fascias of the pectoralis. And then we have DP flap with the blood supply internal mammary artery. If you have like a what do you call it? The all thickness cheek defect, for example, then you can have both of the flap PMMC and deltopectoral PMMC for the inner lining and then deltopectoral for the outer lining. That also can do. This flap does not contain muscle, so usually it's relatively not too bulky. We have also sternocleidomastoid flap. We usually use it for the mandible, for ORN, for postparatidectomy when you need some kind of soft tissue under the skin. You also can use your tracheal and pharyngeal reconstruction. Recently, I use it to cover my fibula because I feel that at some point my plate can expose the skin. It's kind of like making like a very tense pressure. So I try to wrap it with SCM to make the surface a little bit smooth so the skin won't be exposed by the plate. And then we have LD flap. It's very good flap. It's very big. Usually we use it for scalp reconstruction or any head and neck defect which requires such a very broad and quite thick tissue. LD can be one of the options as well. This is Professor Ho's favorite flap. That's why I put it here in one of the slides. This is for you, Prof. So this is buccal fat pad flap. To be honest, I don't use it here because most of my cases requires more than just buccal fat pad. But professors like this flap, and I can see why, because it's quick, it's simple, easy, no scar, it's hidden intraorally, is perfectly good for such a local flap and regional flap. The disadvantage, of course, is only for small and medium defect. You can use it either for the palate, for the cheek, or if you have marginal mandibulectomy defects that does not want to get any free flap reconstruction, you also can use this buccal fat pad to flap as well. And then we have a submental flap. You know that you raise it around submental area, and then you can use it for reconstruct the cheek, the lips, as well as the tongue. We can have platysma flap with the blood supply from the submental as well. And the indication, if you have the defect in floor of mouth, then you can always rotate it, the platysma from the cheek to enter through the submandibular regions, go up, and then you can reconstruct anything intraorally from the tongue, from the cheek, retromolar, trigonum, as well as the lining of the lower lip if you need to reconstruct the lower lip. And this is just one of the table that that's showing what kind of regional flap that's possible and probably recommended for any type of the defect. And then coming to more complex flap, which is a distant or free flap. We know that for soft tissue, we have radial forearm, ALT, AMT, LD flap, jejunum flap, and so on. And then for composite reconstruction, where you need to replace the bone, then you have fibula, scapula, iliac crest. And then this is one of the example for radial forearm free flap. We can use it for small to medium lesion. For example, that if it's a female patient with a orbital tumor that need accentration and suprastructure maxillectomy, then if you remember my other case, then ideally it has to be put either with radial forearm or ALT, for example, but the patients refuse it, and therefore I put forehead flap. I a little bit hesitant to put forehead flap for female because the scar does not look very good. You have to put skin graft on the top of the forehead defect. And that's why if you able to do it, then it's better to use radial forearm free flap. It's very easy to harvest, and then the operating time is lesser and quicker than any other soft tissue reconstruction. And then we have LT flap for large and medium defects that need soft tissue cover. Then we usually use it for buccal or large tongue defect more than hemiglossectomy, parotid, orbital, or the scalp itself. And then we have LD flap. I use it commonly for the scalp where you need such a broad soft tissue cover, and then usually we put skin graft on the top of it. And the reason is because you can always put or include some LD skin as well, but then you're gonna leave quite a big defect at the LD side, where you need to reconstruct with the skin graft as well at the back. And to put skin graft at the donor side of LD, it's quite difficult to maintain because the patients, you cannot ask the patient to lay down all the time. By the time he's moving, then the skin graft is also can be moved. So we're trying to avoid of putting skin graft in the LD donor side. And then we have jejunum flap, usually for oral and hypopharyngeal reconstruction. To be honest, I don't do it here because we rarely have pharyngeal reconstruction or hypopharynx. But when I was in Tata, most of the time when you have like a complete segment of the pharynx that's lost, then you always have many options, including gastric pull-up and then jejunum flap. Or sometimes you can always use regional flap like a pectoralis major, for example. Sorry. Fibula flap is the ideal bone reconstructions. Usually this is two-team approach where one of the surgeons, one of the team will do ablative and the other one will harvesting the fibula flap. It's very robust. It's the blood supply is from peroneal artery, and you can use it for maxilla or for mandibular. And then scapula free flap. Compared to the fibula flap, scapula is a little bit complicated in the sense that, I'm sorry, in the sense that you need to change the position of the patient, so you cannot do it simultaneously. So usually when you're doing scapula free flap, then it's gonna take longer time compared to other bone reconstruction. And then we have DCIA, where you have iliac crest free flap. Usually we use it for a lateral and hemimandibular defect because it cannot be that long. Like when you raise iliac crest flap or iliac crest bone, then you know that the maximum like you can get it's around 10 centimeters. So you cannot go beyond that. And based on that, if you have like subtotal mandibulectomy defect, then you cannot think about iliac crest free flap. You have to think either fibula or something else, or the combinations of 2 or 3 bone flap. So what is the take-home message? We know that right now the free tissue transfer is the mainstay for complex head and neck reconstruction, but I think the knowledge and the skill of local and regional flap is still very useful because not every cases can be reconstructed with the free flap, as we know that it depends on the patient's factor, it depends on the surgeon factor, it depends on any other factor, including your supporting system as well. So you need to consider all the reconstructions. Surgery has an art itself because you need to choose which flap to use, whether your skill can be used to reconstruct the flap, whether you have any supporting system to support you for doing the reconstruction, such a complex reconstruction or not. So there are so many things to consider, and I hope my talk today can give you some kind of brief introduction about flap in head and neck. Thank you so much.
Thank you, Dr. Lina, for this wonderful talk. Now we open to the floor to, if there anybody have any current questions or discussion.
Good morning.
Dr. Malinda, it's good to see you.
Good morning. Good morning, Nina. Thank you very much for your very nice talk. And thank you, Prof. Sheng-Po. Sorry, I did not use my video, but I would like to thank Prof. Sheng-Po Hao because of this good chance to share the knowledge. So, Nina, I would like to ask you, in the laryngeal cancer with the involvement of the esophagus, what is your suggestions to do the treat this esophageal involvement? What is the better or the much used flap did you use to of course the free flap, to treat this esophageal involvement? And are there any limitations to do this involvement of the esophagus? Thank you, Nina. Good luck and success.
Thank you, Dr. Marlinda. I think I just briefly mentions that it really depends on how much of the tissue how much of the esophagus that missing, how much of the circular lumens that missing. Like if you still have approximately, if I'm not mistaken, the width is around 3 centimeters, then you can always use radial foramen, for example. Or if you do not have the experience to do the free flap, then the regional flap that we can use is probably pectoris pec major flap. But as I said, that pec major flap has some kind of limitation. For example, if it's a female patient, then it's very hard to put PMMC around the pharynx to reconstruct it. It's because the female patients will have such a, especially if it's got large breast tissue, then it will be difficult to kind of like fold it. You need something to get a better folding so it can actually create like a lumen. So I think the ideal would be free flap. If it's a full circular one, will be jejunum. If it's less, then it will be radial forearm. But otherwise, if you cannot do anything, then it can be done by gastric pull up or as well as pectoralis major flap. Probably Professor Ho want to add something? Prof, you need to unmute yourself.
Yeah, I completely agree with you. I think your answer is just perfect. Thank you. And there's also a question from Nepal, from Professor Namaya Thapa. Her question would be, thank you, Dr. Nina, for excellent talk. What prop do you advise for large cheek defect?
Large cheek defect, is it through and through defect?
Yes.
Okay, so if you can pursue free flap reconstructions, you can have folded ALT. So you bipedal ALT into inner and outer lining. That's one. Or you can have PMMC flap, which you bipedal it also. You fold it to be inner and outer lining. And then, of course, otherwise, you can always put double regional flap. As I say, the inner lining can be PMMC flap and outer lining will be DP flap. It will look ugly at first, but sometimes we require this kind of panic if we're dealing with such a very bad prognosis patient or the patient does not want to require any free flap reconstruction. I can see someone want to comment about pharyngeal reconstruction, Prof.
From someone for pharyngeal reconstruction?
Let me check. I just saw the message. Oh, Prof. Rajiv.
Yeah, Rajiv, yes.
Hi. Sorry. Thank
Good
you, Nina.
morning, Prof.
Hi. It's a great talk. It's a great talk. Can I just give a small comment on that pharyngeal defect? As a
Sure.
matter of fact, yeah, we had one yesterday, just finished that case in which we choose the free flap. The comment that I want to give is it's good that you show about this jejunal flap. We had that case in which we do a jejunal flap. Good in terms of swallowing, but the problem is the oncologists, they are afraid of radiating the neck with a jejunal flap in the throat. So that's why I think if let's say this is a salvage surgery, I think jejunal flap is good because they have a dual supply. But if you need to go for radiotherapy, I think maybe use the tubular ALT flap because after that we can go for radiation.
Yeah,
Thank you.
yes.
Otherwise, great talk, Nina. Thank you.
Thank you, Prof. Rajiv. I also need to add that jejunum flap is quite a risky flap. You really need to have like a very experienced microsurgeon team because the ischemic time is only 2 hours. So you have to finish all the reconstruction, which is done in 2 hours. So you really have to make sure that this done completely. To be honest, people from Tata, they can do it very fast.
Yeah.
Otherwise, they even the plastic surgeon there, they can harvest the jejunum by themselves, so they don't need digastric or GI surgeon. So that's how good it is. But yes, thank you so much, Professor Rajiv.
Thank you, Nina. Good talk.
As a comment from Prof. Narmaya. So Prof, if it's only skin, then we can always use some rotational flap. As I say that the local flap that we can use either from, I don't know which part of the cheek was it, but you can use it either nasolabial or rotation flap, or even mustarda flap, anything you can transport. And if it's very lax skin, then it's easy to be used. If it's such a big one, you can put DP, but as I said, DP flap needs to be there for like 2-3 weeks. So you need to consider that factor also if you require such a very large skin as well.
Nina, I do have one question for you. You see, here in Taiwan, we have many patients actually underwent chemoradiation therapy and then have a recurrence or something. And then because the defect, we remove the tumor and the defect was within the radiation field. So although the defect might be just a very small defect, 2 to 3 centimeter in diameter defect. However, is any suggestion for any regional flap, because you know, all the regional flap would be within the radiation field, and how you solve the problem? Yep.
That's quite tricky in the sense that anything to be put after salvage flap after chemoradiation, it's not going to be good. But again, we're trying to use the simplest one. Probably I'm not going to consider a free flap unless if we do not have any option. I still feel that regional flap is better. So it depends on where it is, Prof. But if it's only small, then either any supraclavicular flap, or which based on the transverse artery, or pectoralis major probably, which is, I mean, like if you put regional flap from pec major, it's not in the area of your radiation.
Yeah.
But probably you have to enter the neck first.
Yeah.
So that's a little bit fibrotic and everything.
Yeah. For that kind of defect, actually, I love very much the pedicle tongue flap, because the pedicle tongue flap would be you really need to look for the pedicle, and then you know, transfer the tongue flap, and the tongue flap, the blood supply with it, although it has been irradiated, but still keep a very good blood supply, and with the thickness to cover, for example, the lower gingiva defect, and to for the exposed bone, of course. And then anyway, but what I learned from my prostate reconstructive you know, teacher, that we should not use any local flap or regional flap, or local flaps, especially within the radiation field. However, sometimes it becomes very, very defect, especially you have this kind of patient, small defect after chemoradiation therapy, and then you don't want to really to do a big surgery, a free flap reconstruction just for 2 to 3 centimeters. So that becomes some kind of dilemma. Yeah.
Correct.
So yeah. Okay. Any other questions?
Hello, Nina.
Hey, good morning.
Hey, I'm Jordan.
So Jordan, you know Nina.
Yeah. 要这个solve the bladder flap and the tongue flap and the throat flap is very good.
Thank you.
Yeah, most of the ENT head and neck surgeon forget about the local flap, but I think the flap, regional or local flap reconstruction is part of the head and neck surgery, and we should not forget about it.
Agree. Yeah.
Yeah, and of course, Lina, you could do free flap now, so it's good. If you
I'm
could
learning, bro.
Come on, you're an expert now.
The
so many complex
flap,
things.
the paddle flap is very how Peter Ho is give me is very technique.
Yeah. All right. Is there any question or comments? 侯宗佑 Peter， 你有没有什么 ？Do you have any questions, Peter? 侯宗佑。If there isn't any more comments or question, let me thank Nina, and I think you have been very successful and become a great surgeon, and congratulations, and especially for supporting us for this retirement webinar. So thank you so much, and please enjoy your day, and thank you for your time. And just give some announcement for the next few speakers. So next week, next Monday, we are going to have Dan Fries from Israel. And then, 2 weeks later, Professor Namaya Thapa will talk about ENT service in Nepal. And then there's some, Professor Goludzinski from Poland will talk about some translational research. And then our friend Alfredo Ponteros talk about the classification of neck dissection, a better one. So thank you for all the participants. It's really good to see everyone here, and I really love to meet all the old friends. And so Lina, thank you again for your great talk. And I hope you keep on your beautiful work in your hospital in Indonesia. And I'm very, very proud of you. Thank you.
Thank you so much, professors.
Yep.
Thank you so much.
All right. All right.
Bye, everyone.
Yep.
Happy fasting.
Okay. Okay. Bye-bye.
Bye.